you can see my slides, and I'm going to start. Please let me know if there are any issues. So today I'm going to be talking about obesity and cardiometabolic conditions, something that is increasingly more important in South Africa. There've been a few things, in Africa, there've been a few talks about HIV and aging and other issues throughout the conference. So I'll be talking specifically about obesity and cardiometabolic conditions. These are my disclosures. So Africa, we are a young continent, yet we've got one of the fastest growing obesity burdens globally. Our median age is about 19 years, yet we've got about 26% of men and 45% of women in Africa with overweight or obesity. So we use BMI to classify overweight and obesity. BMI is imperfect, so BMI of over 25, which is your height divided by your weight divided by your height, or especially for African populations, because this was made by actuaries, but it's good for us to see population level data. But the disease of obesity, we need to women on the continent living with overweight and obesity. By 2030, non-communicable diseases, including hypertension, cardiovascular disease, will be the biggest killer of Africans, overtaking malaria, TB, and HIV. And in the world, there are only 13 countries that have full system readiness for obesity care. None of these are on the African continent. And in Africa, we've got very few nations with formal clinical obesity guidelines. South Africa just released the first obesity guidelines just 2 weeks ago. But why? Why is this happening to Africa, and why is it happening now? So if you look at this slide, yes? Hello, was there any feedback for me? I will continue. So Africa is very vulnerable when it comes to obesity for a couple of reasons. So our epidemiological transition. So if you look at this map of the world, if you see the green colors, which is India and Africa, we've changed from the way we ate. So we eat very different from the way we ate as children or how our grandparents our grandparents eat. And you're now seeing more women having more overweight than men, adults more than children, and people of a higher socioeconomic status versus a low socioeconomic status. But women in particular are extremely vulnerable. By 2030, half of African women will have overweight and obesity. And in my country of South Africa, type 2 diabetes is now the biggest killer of women. Other reasons that we're vulnerable is this picture, and you can see it in different parts of the country. This is actually showing the neighborhood that I live in Cape Town. On my left, it's a place that is safe, you can walk around. And on the right, if you can imagine, there are not a lot of, we call them food deserts when it comes to food. You're not able to plant or grow food because you don't have a lot of space. And you also don't have space for you to exercise. And then for those that have children or work with young people, it's the aggressive marketing of ultra-processed foods. So we have more fast foods in both the Africa region and the Middle East region, growing by about 13%, which is compared to about 7 or 8% in other parts of the world. So think of the city that you're in. How many KFCs, how many pizza places, etc. are you seeing around you? We call that an obesogenic environment. And young people, this is really important. We think of obesity as something that affects the US, the UK, but actually it is a low and middle income country, and the BRICS countries being most affected. So this is looking at the top 5 top 20 countries with rapid increase in the proportion of obesity among young people aged 5 to 19. And if you look at them, Vietnam, South Africa, Namibia, Eswatini, etc., it's all low and middle income countries and quite a few African countries. Now to change gears to people living with HIV. I mean, in this conference, we've heard some of the challenges, but a lot of successes of what we've been able to do when it comes to HIV care and treatment. And what we've done is that in almost all areas of the world, we've reduced life expectancy. We've increased life expectancy significantly. And in East and Southern Africa, where we've got the most Africans living with HIV, that has life expectancy has increased by nearly 60%. However, what you may not know is that people living with HIV live 16 fewer years in good health. So yes, we've extended your lifespan, but are you living well? And what we're seeing is that people are having huge numbers of cardiovascular disease, non-HIV related cancers, liver disease, type 2 diabetes. And this is really, really important because people living without HIV usually get comorbidity, which we call another disease, hypertension, etc., usually in their early 50s. But people with HIV, we're talking about in their mid-30s, which is important when we look at our systems and when we look at integration of HIV and non-communicable diseases. So there are quite a few cardiometabolic diseases. Because I only have a short time to talk, I'll only speak about a few of them, which are highlighted here, but I want to make you aware of quite a few. I'll start with the first one, obesity. Obesity has been described in a lot of conferences and in a lot of things that we've seen. And around 1 in 6 of people living with HIV gain about 10% of their body weight within that first 2 years of antiretroviral treatment. Interestingly, people with HIV gain weight about 3 times as fast as people without HIV. We've seen this in a big cohort called the ICASA permanentes cohort, where this was described. Women and certain groups, these are Black people, and this is people of African descent, both within Africa and also cohorts in the UK and in the US, are more likely to gain weight, and women as well. This is a study that was done, that I was involved in, called the Advanced Study. And as you can see, on 3 regimens that are being used with a 5-1 being phased out for both men and women, across the 4 years of the study, there was significant weight gain. But there are some antiretroviral treatment, integrase inhibitors, TAF, that are associated with increased weight gain. So I'm just going to summarize this. So we know there are certain drugs, certain ethnicity, the women, and then also the things that I spoke about at the beginning, urbanization, lifestyle factors. Those are important. But obesity, HIV, which was associated with wasting disease, those that have lived and worked with people living with HIV know what it was like less than 20 years ago when we were taking our relatives in wheelbarrows because they were so sick with low CD4 counts. That is not the face of HIV usually anymore. But obesity is associated with over 200 diseases. And in people living with HIV, this is happening earlier and also faster than the general population. And this is a narrative review that I did with a few colleagues that summarizes it. But there are other people that that are affected by cardiometabolic. This is a key population. These are women who are living with HIV and in menopause. So if you look at the 2 things, HIV, you've got a high risk of cardiovascular disease, liver disease, etc. Then you look at menopause, and if you put in HIV medication, you're seeing that women are affected. This is really important because we didn't expect women 20 years ago to be, living in menopause, living with HIV and in menopause and aging. So this is really important, and there are a lot of resources that are available there, and there's a big knowledge gap of African women with menopause, especially when it comes to their cardiometabolic outcomes. I will then speak about the second last disease, which is diabetes. The general factors of diabetes are higher BMI, going back, older age, central obesity, family history. I can't see people in the room, but if you were to lift your hand, if a first degree relative is living with diabetes, I mean, I will lift my hand. I've got diabetes, is quite prevalent in my family. And this is something that we have to also look at because most of the expenditure is out of pocket. While you're able to get antiretrovirals generally for free, how about your insulin and metformins and so forth? That is more difficult. Then the HIV specific risk factors, some of the exposure to older ART, elevated systemic inflammation that we have even when people are suppressed on antiretroviral treatment. And then just to sum up all these diseases that I've been talking about, and if you'd like to just take anything from my talk, is the fact that these diseases don't sit in silos. We call this, these causes another. So if you've got excessive dysfunctional adipose tissue, excessive weight, that affects your kidneys. So we call it cardiovascular kidney issues. And then this, again, causes cardiac remodeling, hypertension, dyslipidemia, diabetes, and so forth. And we have this vicious cycle of people who are living with multimorbidity of cardiometabolic disease. But one thing I really want to remind us in the HIV community, a country like South Africa, we delayed when it came to antiretroviral treatment, and it caused a lot of death. But now, as a continent, 45% of deaths by 2030 are going to be because of non-communicable diseases. Our systems ready? Our healthcare workers trained to deal with this? Do we have funds allocated by our governments? And also, when it came to HIV, we also centered around our community where people said, I refuse to die of HIV. Yet we accept diabetes, stroke, as part of the ways that we die on the continent. And I just want to remind people that no, it isn't. Non-communicable diseases are robbing us of all the gains that we gained with HIV. And I want to leave you with a few takeaways, that people with HIV are living longer, but develop obesity and other cardiometabolic diseases and multimorbidity. So it's just not one disease, we see several. Weight gain is faster, more complex, and it's multifactorial. And what we're seeing people living with HIV is what we're seeing in the general population. But inaction has costs, leaving you with this pictogram from the World Obesity Federation, which is showing the percentage of adults with type 2 diabetes who are not being treated. So if you look at the African continent, right, the dark reds and the oranges, these are people who are in HIV care that are coming in and coming out with diagnosis of other things. Thank you all for your attention. I would like to thank my collaborators who have been helpful in the preparation of these slides, and I'll hand over back to the chair. Thank you.
Thank you very much, Doc, but you didn't introduce yourself. I'm sorry about that. Kindly introduce yourself, please.
Oh, hello, everyone. Let me introduce myself. I am Dr. Nomathemba Chandiwana. I am a physician scientist working at the Desmond Tutu Health Foundation in Cape Town. And my work is at the intersection of HIV and non-communicable diseases, from research, but also from advocacy, as I think this is the next wave of place that we should place importance in the HIV community. Lovely to see you all.
Thank you, Dr. Chandiwana, for the eye-opening presentation. Can we give her another round of applause, please? Thank you. I'd like to find out if we have Dr. Mamy here. Okay. and then Prof. Attinsounon. I'm pronouncing it the Ghanaian way. Okay, we don't. So we still have a little time, and so we can take questions from Dr. Chandiwana. Questions, please. She has given us a very interesting presentation, and I did some work on adolescents and young adults living with HIV, NCDs amongst them. And a lot of the information she gave us is actually supporting the findings we had in our study. Unfortunately for us, the adolescents have had a lot more NCDs than the young adults, and it was more common amongst those who got their HIV through mother-to-child transmission. So it is a big problem, and as she has highlighted, we need to look out for this, put in the necessary structures to prepare for this, for the outcome of this obesity epidemic, or should I say pandemic. Because as you said, inaction is costly, solution must be integrated, affordable, and scalable. Any questions, please? All right. Yes, sir. I hope we still have Doc on the line. Yes.
Thank you so much for the insightful presentation. My name is Mwayuma from South Africa. I just want to find out, so the concept of One Health and integrated care, where HIV, diabetes, as well as your kidney disease and the likes, have been proposed as an approach to resolving the issue of having infectious and non-infectious diseases being treated differently. I just want to find out from your perspective as to whether that was tested out and whether you have seen progress in as much as the management of diabetes is concerned in this particular population. The second question that I have is actually with regards to the issue of, the word just stepped out of my, I just lost my train of thoughts. With regards to the issue of, what do you call it? Munjaro. Is it Munjaro? The one that people vaccinate themselves with. I think it's a diabetes treatment. What are some, because there's this thing that is going around that in as early as someone gets diagnosed with HIV and they start picking up, weight and all of that, in order to control for that weight, we see a lot of people just going to the diabetes medication as a weight loss mechanism. So from your perspective, I want to find out if there are any other recommendations that you guys have actually, picked up that can be incorporated at the early or the acute phases of HIV infection. Thank you so much. Just to prevent the long-term weight gain and the ultimate diseases that come after that. Thank you so much.
Yes. Thank you, sir, for your questions. Dr. Chandiwana, can you take the two questions, please? Thank you.
Yes, I can. Please call me Nomathemba. So the first question around universal healthcare. The public health physician in me, I'm a big advocate of universal healthcare because it's not, diseases are not, they live in the same person. But with that said, I feel that for you to build expertise within a program, right, you need to have siloed services that then become integrated. I'll give you an example. When HIV started, and that's been one of the biggest successes that we had with HIV, we had siloed services. And I know the chair there, like, for example, youth-friendly services or services for children with HIV were specialized. And then with time, children could be seen in more, in more integrated services. So I think we probably need a mixed model, but certainly working at primary care. We have done some work in this part of the world where people living with HIV who go see a nurse, etc., every 3 months, it takes them between 4 to 7 years to get a diabetes diagnosis. So that integration is not working. And when we say integration, what we're doing is we're piling on every disease to that nurse in that clinic for her to be an expert or for him to be an expert, which I think is not quite realistic. So I do think we probably need to have a few models, and those models can't be within facilities. Community-based models can be very, very effective, especially at picking up people, because people don't walk into clinics as they should. So having community-based screening would be important, and finding ways to work primarily at primary care with also non-specialized providers. So that would be my answer there, that we probably need a hybrid model, starting with if diabetes is going to affect a lot more people than HIV. I think to just put it in the system without extra support would be difficult. To answer your second question about GLPs. So GLPs are a class of drugs. I'm sure you've heard a lot of them. Mounjaro, semaglutide, all our celebrities are getting slimmer. These drugs are amazing if they're used appropriately. So the WHO on the 1st of December released GLP guidelines, which I really encourage for most people to look at. And what we are seeing now is GLPs are another test of equity, where you find high-income countries have GLPs available, and then we're telling Africans to exercise and eat well. So obesity is a disease, and while supportive things are important, it's important for you to not eat processed foods, for you to exercise, etc. Diseases need drug treatment. So I think sometimes we exceptionalize obesity. You would never tell anyone with type 2 diabetes that, yes, you've got diabetes, don't take insulin, exercise. Obesity is the same, and I think we should see those drugs in the same way. But the cost is very expensive, and it's something no government can afford, including the government of Denmark, where these drugs are done. So, but this will be evolving in the next few years, but we need to put pressure to say Africans shouldn't wait for first-in-class medications 5-6 years after the rest of the world has received them. Back to you, Chair.
Thank you very much, Nomathemba. Can we take more questions? It was a very interesting presentation, so I was hoping we'll get it was so straightforward and very simple and easy to understand. Okay, since we still have a little time, we can have, if we don't have questions or if someone thinks up a question, all right. Please go ahead, man.
Okay, thank you very much. I came in a bit late, so I don't know. But I'm curious. From what I heard, it means that in the next few years, this is the trajectory we are heading towards. Is there anything we can do to prevent this? I don't know whether she's talked about it, but I'm curious. What can we do to prevent it? I mean, once we know it can happen, there should be a way we can reverse it. So if she has anything to share, I'll be grateful. Thank you.
All right, thank you for the question. Nomathemba, over to you.
Okay, and that's a really good question of what can we do now. So there's another document I'll refer you to. I can share it with the chair so that these are available. But there's a WHO acceleration plan to stop obesity, which has got 11 proven interventions to slow down obesity. But with that said, you know how we speak in HIV that we want to do 95, 95, 95, right, of people living with HIV? In the obesity world, the targets are extremely non-ambitious because we are looking at a 0% increase in obesity. And to give you context, we are preparing for World Obesity Day next year, which is on the 4th of March. And the theme is half of humanity, or 4 billion reasons. So about 8 billion people in the world. And by 2030, half of all people in the world will be living with overweight and obesity. Just that is a lot of people. And some of the things that we can do, there are policy things, increasing tax on sweetened beverages, the early food environment, stopping marketing towards children. There's also front of package labeling, which is important. And then having obesity management and care within, having a strategy for countries, training healthcare workers, and also using models that work. So what would work in Niger would be very different from what would work in a country like Eswatini. So you need to find models that work. So there are about 11 proven and also the WHO best buys. But with that said, that needs a lot of political will. And that's what's lacking when it comes to non-communicable diseases. If I was speaking around any topic with HIV and I was telling you that over half of these people are unsuppressed or they don't have access, it would be quite shocking. But because obesity, it's not, or type 2 diabetes, it's an insidious disease, right? It's not like it happens today. It happens over years. That weight gain, which is about 0.5 kgs per year for the average person, accumulates in about 10 to 15 years, with you having cardiovascular disease, stroke, etc. So I think that's what's difficult to make the case for governments and for individuals. I mean, I spoke to one of our advocates who lives with HIV, and I asked her, I said, you have been standing for the last 30 years, right? Advocating for drugs at a cheaper price, lenacapavir, TLD, everything. Why are you silent when it comes to non-communicable diseases? And she said something that stuck with me. And the language and things that we need to use and work with our communities. She said, HIV is an unnatural way to die because we often think of it affecting young people, lives lost, vertical transmission, and so forth. However, diabetes, stroke, hypertension is how people die. So we have to change that mindset to say, actually, this is not a normal way to die. And also, if you look at the design, I mean, you're at a conference right now. What food has been available when you went to eat? Were there soft drinks there? Did you walk today? What food were you offered at your hotel? So if you look around us, right, it's hard to make a healthy decision because we're putting it on the individual. It has to be made easy. Must be easy for me to walk, to be safe, for a child to be able to, just to give you an example, there's more sugar in juice that we give our children every day than a Coke. So there's a lot of education that we need to do. Even big food. I think you've seen it in the media that Nestle has put more sugar in products coming to Africa than the rest of the world. So there is also profit. The reason that KFC tastes delicious and you'll think of it is because it's been made amazing to taste good. So the tactics that we saw in tobacco is what we're also seeing in processed foods. So to answer your question simply, it's very hard. It's going to be harder than any disease that we've looked at, but we need commitment from everyone. It's just not the health sector.
Thank you very much. My question is how we assess obesity amongst blacks and among whites, BMI, waist to hip ratio, etc. Which would be best for blacks? Since we are at higher risk, we would want a standardized measure that would not necessarily be one size fits all because we have different body types, different morphologies. So there's the argument that using the BMI actually works against blacks. What do you have to say about this, and what would you recommend we use to assess obesity amongst blacks? Thank you.
It was made by actuaries. It's good for population level data, but for individual health, it's not great or helpful at all. So there have been newer studies that have looked at using different things. and even at BMIs of about 32 that are seen as overweight or obesity in Black women of African descent is considered healthy because the body type is different. But there's actually a really nice paper, a new way that was proposed by the European Society of Obesity called the Lancet Commission. That's not looking at obesity based on body type, but based on function. So I could be the same weight and height as you, but I'm struggling with sleep apnea, I've got type 2 diabetes, I don't exercise. So not looking at obesity, but looking at obesity plus function and disease. Whereas you could be the same weight and height as me and you've got no issues, your blood pressure is okay. So the Lancet Commission is what I think would be great, but that's more looking at an individual level. Population level data, there's some studies now that are looking at characterizing obesity among African populations. So what is that cutoff? But one thing that I think, what I use with our patients is actually abdominal circumference. Very easy to do. Everybody's got a tape measure, right? That is something that you can do, waist to hip ratio. So that is what I would recommend at the moment, but also look at, this is an evolving field, but the Lancet Commission that's looking at function. Because you also don't want to body shame, right? You know, we're going into Christmas now. Everybody has that aunt who will comment about your stomach or or elsewhere. It's not about shaming people. The conversation should always be around health.
Great. Thank you very much. And I think our time is up. Thank you, Nomathemba, for your very interesting and enlightening presentation. I believe we all have our take-homes to go fight obesity in our various clinics, and even starting with ourselves, that we should get active, watch what we eat as much as we can. Thank you all for your attention. Good afternoon.